Hey everyone, this is Dr. Boyd. Welcome back to Parently. Today, we're going to talk about one of the most difficult diagnoses in pregnancy, miscarriage. We're going to use a lot of biology today, so please hold on, please move forward with me. It will help you as a patient understand what we're talking about as a healthcare provider. Miscarriage. That is a lay person's term for pregnancy loss. In medicine, we call it a spontaneous abortion. Please, before you take off from this video, understand why it's called a spontaneous abortion. Make sure you separate it from an elective abortion that you hear about in politics. A spontaneous abortion means it happens spontaneously. You did not have anything to do with it. That's important to understand as a woman because many women feel guilty when they lose a pregnancy. So spontaneous abortion is any pregnancy loss that occurs spontaneously prior to 20 weeks gestation. After 20 weeks gestation, if you lose your baby, it's called an intrauterine fetal demise, IUFD, but they're separated by that timeline of 20 weeks. Most women have miscarriages, have spontaneous abortions prior to 8 weeks. Most pregnancy losses occur in that first 8 weeks, and many of them occur without you even knowing it. But we're going to take several scenarios today and explain to you what you may witness as a patient if you come into your healthcare provider's office with the possibility of miscarriage. So we've defined the diagnosis terminology-wise. Any loss of pregnancy prior to 20 weeks is called a miscarriage or a spontaneous abortion. Why? Why do I, as a pregnant woman, why am I losing my pregnancy? If you have 100 women that get pregnant, 20 lose their pregnancy. The pregnancy loss rate across the population is 20%, 1 in 5. Why does that happen? There's 7 different categories, 7 of pregnancy loss reasons. It's interesting, number 7 is unknown. We don't even know the reason. But the first most common reason for pregnancy loss is trisomy, an abnormal chromosome complement. That means when the sperm and the egg got together, they fused, they merged information. They did not create a normal woman, which is an XX chromosome complement, or a normal male complement, XY complement. So again, XX is female, XY is male. There should be 46 chromosomes. In certain pregnancies, you have an extra chromosome that's called a trisomy. So a Down syndrome baby has trisomy 21. Those babies, after they're created, oftentimes are incompatible with life. So they're lost early. They're lost prior to 8 weeks for most of them. But that is the patient that you may be in a scenario right now that is experiencing this. It's emotional. You cry and cry and cry. Whether you want and understand a pregnancy, it's important to know that you oftentimes will go through this very emotional process, 1 in 5. So, what to expect when you get to your healthcare providers? Typically, you call the office, you've had a home pregnancy test that's positive, and you bleed or spot, and you call the office, and oftentimes we will have you come into the office. What to expect when you get there? First of all, we determine if you're truly pregnant. This scenario exists more than you can imagine. You think you're pregnant, you've had a home pregnancy test at home, and then you get to the office and we check a pregnancy test and it's negative. How could that be? Believe it or not, you may have already lost a pregnancy at this point. Most women know this is the scenario. You call the office, you're spotting, you come to the office and we examine you. We examine you bipelvic with a speculum. We do an ultrasound and we do blood work called an HCG level. Human chorionic gonadotropin. It's the pregnancy hormone level that's in your blood. So I'm going to give you several scenarios that can help you move through this process knowing which one you fall in. Category or scenario number 1. You're a pregnant woman, you have acted the office, and you have an open cervix on exam. So we place a speculum and we notice your cervix is open. You're bleeding. So the next thing we do is we do an ultrasound. Whether you have a beating heartbeat of the embryo or not, if you have an open cervix and you're actively bleeding, you will lose the pregnancy. That's called an inevitable abortion. Sometimes your healthcare provider will also perform the HCG level, but most of us do not. If you have an open cervix and you're bleeding, whether you have a beating heartbeat of your baby, we know that that pregnancy is going to be lost. And then we prepare you with 2 possibilities. You're going to pass this spontaneously. In other words, you're going to bleed, you're going to have clots, and you're going to have discomfort. It can even be pain because it's your uterus contracting that's trying to push that products of conception out of your uterus. Advil, ibuprofen, 800 milligrams every 6 to 8 hours, and with the understanding that you're going to bleed heavy. Most women do fine physically. Some women, though, bleed so heavy that they have to go to the hospital and have a D&C. That's where we place a suction device in your cervix, into your uterus, and we remove the products of conception. Most women don't have to have the surgery. So the second scenario is what we frequently see in clinical practice. We have a woman call the office and she has spotting. We have her come to the office and we examine her and she has a closed cervix. Maybe she has some spotting, maybe she doesn't. We perform an ultrasound, and if you're a minimum of 5 weeks gestation, we should see a beating heartbeat of the embryo. If you're not quite 5 weeks pregnant, we may have to perform an ultrasound a week later to give us that diagnosis of whether you're truly pregnant and it's viable. We also perform an HCG level. We simply get a blood test. We want to know if this is rising appropriately. So if we draw an HCG today and we check it 48 hours later and it doubles, then I can give you an answer as a patient. The HCG level is rising appropriately, and that is a good news for a viable pregnancy. Some providers, and I'm one of them, we also use a progesterone level. That is a blood test looking for the progesterone hormone in your body. If you have a progesterone level of greater than 15, that bodes well that you have a viable, successful pregnancy. A progesterone less than 15, oftentimes those are non-viable pregnancies. So that is a blood test that helps us. The third scenario is a woman that has no problems at all. She comes in simply because she's pregnant. We want to get dating ultrasound, and we examine her by ultrasound, and we see no heartbeat of the baby. We're greater than 5 weeks, and we give her a diagnosis of a missed abortion. This is a very difficult scenario because women that have bleeding oftentimes will come to the office with the expectation that they may be losing the pregnancy. A woman that simply comes in because she knows she's pregnant, she's going to get her first ultrasound, and we give her a diagnosis of a missed abortion, that woman is extremely emotional. It caught her off guard. So at this point, when you've been given a diagnosis of a threatened miscarriage, what to expect? If we're confident as a healthcare provider that you're going to lose the pregnancy, or you're in the process of losing it, or you have a missed abortion and you may start the process, what to expect? First of all, it's important to understand that most women pass their products of conception spontaneously. Expect to have bleeding, expect to have clots, and expect to have uterine pain, contractions. Your uterus is contracting to rid itself of the products of conception. Expectation, that's the most important element. Plan on taking ibuprofen, Advil, 600 to 800 milligrams every 6 to 8 hours. This will help the discomfort. Some women bleed so heavy that they have to have a D&C. A D&C is simply a suction device that's placed in the uterus, and it will remove the products of conception. That scenario exists just for a small percentage of women. Again, it's so emotional, rarely physical, other than you know you're bleeding heavy and you can get into trouble. But it's much more emotional than it is physical. I will mention the missed abortion patient. That patient is offered two scenarios by the healthcare provider. The body will simply resorb the pregnancy, pass the pregnancy, or you're offered a D&C. Many women will take the D&C because they want the process over. And when I say to them, if you simply manage this expectantly, it may last 1 to 2 to 3 weeks. That oftentimes is too much for women, and they accept the D&C as a moving forward process. How long after the process is over should you wait to get pregnant again? 6 months before you move forward with another pregnancy. Should you contracept during this 6-month process? You need to decide that as a patient. Talk to your healthcare provider about that as an option. So when you're moving through the process of a miscarriage, whether it is spontaneous, threatened, or whether it's a missed abortion, please consult, talk to, cry upon your husband, your mother, family members, friends. Remember, pregnancy loss, 1 in 5 women go through this process. Many women then have gone through this process. They can help you through this very emotional, difficult time period. But if you don't talk to them about it, how can you expect them to help you? That's a great bit of information, and I encourage you to move forward with talking to family and friends.